Dermal vascular alterations in acute inflammation. Different segments of the microvasculature contribute in different ways to acute inflammation. Local sites of inflammation are perfused at a higher level, primarily because of a shift in the balance of vasodilatory molecules released by the EC of the arterioles and, to a lesser extent, the capillaries. The principal mediator for this change is an increase in the synthesis of prostacyclin, resulting from a cytokine-induced increase in the expression of cyclooxygenase, COX-2. The resultant increase in blood flow results in local warming, calor, and increased redness, rubor, of the inflamed site. Venular EC disrupt their intracellular adherens junctions, allowing the extravasation of large plasma proteins producing swelling, tumor. Other changes are in the display of surface molecules by the venular ECs that can serve to capture circulating leukocytes. Chemokines may be made by the ECs or may be produced by sentinel cells of the perivascular unit and become displayed on the EC luminal surface. Cytokine activation of EC can also promote coagulation by downregulating thrombomodulin synthesis. Coagulation may be propagated by EC release of plasma membrane-derived microparticles. Production of chemokines that preferentially activate T cells and effector cells mostly associated with Th1 or Th2 type adaptive immunity, respectively. In chronic inflammation, endothelial cells, ECs, can become persistently activated. A key driver is sustained TNF stimulation. This leads to continuous, high expression of adhesion molecules. ICAM-1 and VCAM-1 promoting firm adhesion of leukocytes. E-selectin persistently expressed at higher levels, enhancing leukocyte rolling. ECs also overproduce chemokines such as CXCL5 and MCP3, which further recruit immune cells. Together, these changes create a state of chronic leukocyte recruitment and inflammation, damaging tissue homeostasis. This shows vascular changes in acute and chronic inflammation. Skin vasculature in wound healing and cancer. Angiogenesis and vasculogenesis. Angiogenesis is new vessels sprout from pre-existing vessels. Vasculogenesis is proposed role of endothelial progenitor cells and mesoangioblasts and resident vascular wall progenitor cells. CD34 plus CD31 minus, SMC progenitors, mesenchymal stromal cells. Molecular mechanisms of vessel formation. Various growth factors acts for EC growth. After initial sprouting, new vessels need to be stabilized and remodeled. Ty1 and Ty2 receptors on endothelial cells bind angiopoietins, mediating dialogue with mesenchymal cells to support vessel maturation. Ephrin B2 and Ephrin B4 help establish vessel identity, marking arterial versus venous endothelial cells. PDGF and TGF-beta recruit mesenchymal support cells, like pericytes and smooth muscle cells, and drive matrix synthesis and cell differentiation. Interaction with the extracellular matrix is critical. Proteins like fibronectin and laminin, together with integrins, beta-1, beta-3, are essential for endothelial and mesenchymal cell survival and for proper vessel formation. Growth factors such as VEGF-A to E-A key endothelial cell stimulators. FGF1 and FGF2, EC plus SMC, PC, fibroblast mitogens, wound hormones. EGF, HGF, scatter factor promote EC growth. Endothelial cell-parasite interactions. Parasites are localized to within the basement membrane of the EC lining of microvessels and contribute to its synthesis and maintenance, and the composition and organization of the basement membrane may modify EC functions. Parasites directly contact ECs, forming adherens junctions involving N-cadherin linkages. Parasites also stabilize ECs by paracrine signals, the best understood of which involves parasite secretion of angiopoietin-1, ANGPT1, which binds to and activates the receptor tyrosine kinase Ty2 expressed on the endothelium. This binding prevents EC-derived ANGPT2 from binding to the same receptor. ANGPT2 acts as a partial agonist, and when its levels increase, it prevents ANGPT1-mediated signaling, leading to disruption of endothelial cell junctions associated with capillary leak, angiogenesis, or both. Skin vasculature in wound healing and cancer. Wound healing. For overlapping stages, coagulation, inflammation, proliferation, and remodeling. Angiogenesis is key during proliferation. VEGF, early from macrophages, later from neoepithelium. FGF2, PDGF, TGF-beta, support vessel growth. Stem cells, hair follicle bulge, dermal sheath, epidermal and bone marrow derived, exact contribution unclear. Clinical note: stem cell therapies have limited success. Tumor angiogenesis. Tumor vessels are abnormal, leaky, irregular. The main proangiogenic factors is vascular endothelial growth factor A, remaining are FGF fibroblast growth factor 2, PDGF platelet-derived growth factor, TGF transforming growth factor beta, HGF hepatocyte growth factor, EGF epidermal growth factor, HIF hypoxia-inducible factor 1 alpha, increases vascular endothelial growth factor. Anti-angiogenic factors, thrombospondin 1, angiostatin, endostatin. Therapeutic targeting. Antivascular endothelial growth factor drugs, example, bevacizumab, aim to starve tumors of blood supply. Normalizing tumor vasculature may improve drug delivery and immune infiltration. Vasculature in wound healing and cancer. In wound healing, orderly, functional vessels and balanced regulation. In tumors, disorganized, leaky vessels, proangiogenic dominance. Conclusion. The skin vascular system is unique in several respects. It is organized into functionally distinct vascular segments which individually or conjointly respond to exogenous or endogenous stimuli, thereby influencing skin disease expression. ECs play a role in antigen presentation, which may increase the likelihood that the antigen is recognized in a timely manner to efficiently recruit memory T cells to sites of danger.